Hi, I'm Richard. I'm a speech and language therapist and a lecturer based in the UK. In today's video, I'm going to provide a step-by-step guide how I critically appraised a cross-sectional study using the JBI checklist for analytical cross-sectional studies. I will be critically appraising psychological impact of COVID-19 on speech and language therapists working with adults in dysphagia, which was written by Rizwana Khalil et al. And published in the Journal of Health and Rehabilitation Research. In this study, the authors attempted to measure the psychological impact that the COVID-19 pandemic had upon speech and language therapists working with adults with dysphagia in Pakistan. I hope this video will be useful to students learning how to critically appraise literature, practicing clinicians, and members of the public interested to know how healthcare professionals evaluate different kinds of evidence. Let's start with a brief definition of what critical appraisal is. Critical appraisal is the systematic evaluation of research to assess its usefulness and validity to a given context. A critical appraisal checklist is a tool used to help readers with this evaluation process. Each checklist contains a set of questions designed to prompt the reader to look for certain information in the research. The number and kind of questions in a checklist depend upon the kind of study you are reading. The Analytical Cross-Sectional Studies checklist used today is published by JBI. This checklist asks 8 questions and asks the reader to rate each question yes, no, unclear, or not applicable. I will now go through each of these 8 questions in turn and attempt to answer them. The JBI appraisal checklist suggests the study should provide clear inclusion and exclusion criteria developed prior to recruitment of the participants. In the Material and Methods section on page 1408, the authors explain that they included speech and language therapists actively engaged in the management of adult patients with dysphagia. In contrast, those who were not willing to participate or those who worked with patients with syndromic conditions were excluded. The authors then explain that they used an online sample size calculator using a 95% confidence level and 5% confidence interval, which justified the inclusion of 89 participants for the study. For question 1 in the checklist, I would say no, the criteria for inclusion in this sample was not clearly defined. The attempt to calculate a target sample size is good practice, but it's not clear whether this was done prior to recruitment or how they arrived at their figure of 89, as you usually need to know the size of the population you were recruiting from. Given that this number exactly matched the number of participants they did recruit, I'm not convinced that the sample size was calculated before recruitment started. I think it's more likely that there were 89 participants available to them, or they managed to recruit 89 participants as part of their convenience sample. In terms of exclusion criteria, excluding people who choose not to participate in your study is not logical, not appropriate exclusion criteria, and arguably breaks the ethical principle of autonomy. The authors provided another exclusion criteria, excluding those who worked primarily with syndromic conditions. They needed to explain what they meant by a syndromic condition or give concrete examples. There was also no rationale provided for this criteria, and arguably there are strong clinical grounds why this group of therapists should have been included. People with syndromic conditions were actually at increased risk of catching COVID-19, being admitted to hospital and dying as a result compared to other groups of patients. It's possible therefore that the speech therapists looking after them were the most psychologically affected of all. The checklist suggests the study sample should be described in detail so readers can decide whether the sample is comparable to the population of interest to them. To do this, the author should provide a clear description of the population where the study participants were selected or recruited from, including their demographics, location, and time period. In the Material and Methods section on page 1408, the authors explain that speech and language therapists currently employed in various hospitals and rehabilitation centres across the Pakistani province of Punjab were recruited using non-probability convenience sampling. In the results section on pages 1408 to 1409, the authors explain that a total of 87 speech therapists participated in the online survey. 71 of these were female and 16 male. They reported age in terms of frequency rather than as a mean or in categories. They found the 2 most common ages for speech therapists were 25 years old and 29 years old. They referred to tables and figures not in the article, so it's unclear how old the other 78% of participants were. 43% of speech therapists held a master's degree in speech-language pathology, and 1% had an undergraduate degree. The authors again refer to tables and figures not included in the article, so it's unclear what qualifications the other 56% of the participants had. They report experience level in terms of frequencies split across categories. 26% of participants had 1 to 2 years experience, 19% had 3 to 5 years, and 1% had more than 34 years. Again, the authors refer to tables and figures not in the article, so it's unclear how much experience the other 54% of participants had. At the start of the results section on page 1408, the authors state the information was collected over a span of 2 months, but do not state when specifically this information was collected. So for question 2 on the checklist, I would say no, the study subjects and setting were not described in detail. For every single demographic variable, how the data was reported was unusual and difficult to interpret, and the vast majority of the data was not actually available to the reader due to missing figures and tables. The checklist suggests that the study should clearly describe the method of measurement for the exposure. The exposure variable in this study is being a speech and language therapist working with adults with dysphagia during the COVID-19 pandemic. For question 3 on the checklist, I would say no, the exposure was not measured in a valid and reliable way. The study does not explain how the exposure was measured or confirmed. We learn from question 1 that it was unclear when the data collection took place. It's not obvious that it took place during the pandemic itself, so the authors needed to explain how they confirmed that the speech therapist had actually worked with patients with dysphagia during the pandemic. The reader might infer that this information was collected when biographical data was collected in the first part of the online survey, but it is unclear. The checklist suggests that it is useful to know if objective criteria were used for the condition, as this decreases the risk of bias. The condition in the study is being a speech and language therapist. So for question 4 in the checklist, I would say no, objective standard criteria were not used for measurement of the condition. The authors did not appear to use any objective criteria for a speech and language therapist, and accepted participants' self-reported face value, which is at risk of bias, though not uncommon in research designs like this. Asking participants to declare whether they are members of the Speech and Language Hearing Association of Pakistan or Pakistan Speech and Language Pathologists Association and about their work status during the pandemic would have ensured a more standardized approach to defining the condition. The checklist suggests that confounding factors are baseline characteristics, prognostic factors, or other exposure variables which influence the direction of the study results. High-quality studies will identify potential confounders and measure them where possible. The study did not report identifying any potential confounders or measuring them to see if they affect the relationship between the exposure and the psychological outcomes. So for question 5 on the checklist, I would say no confounding factors were identified. The study looked at psychological outcomes, so confounding factors would be things that could potentially affect the psychological state of the speech therapists. It would be appropriate to identify confounders such as pre-morbid mental health status or other factors known to contribute towards negative mental health outcomes such as socioeconomic status. The checklist suggests that confounding factors may be dealt with within the study design, such as matching or stratifying sampling of participants, or in data analysis by using some form of multivariate regression analysis. We learn from question 5, however, that confounding factors were not identified, so for question 6 on the checklist, I would say not applicable. The checklist suggests establishing the objectivity of the outcome measure, how the measurement was conducted, and whether the measurement tool was a validated instrument. The outcome measures in the study were the DAS-21 and IES-R. These are validated instruments used to screen for psychological difficulties. The measurements were administered to participants during the second part of the online survey. So for question 7 on the checklist, I would say yes, the outcomes were measured in a valid and reliable way. The checklist suggests when deciding whether statistical analysis was appropriate or not, to consider whether there was a more appropriate method that could have been used instead. The methods section should be detailed enough for readers to identify which statistics were used and how specific confounders were measured. In the material and methods section on page 1408, the author suggests that they were going to use IBM SPSS to perform a t-test and an ANOVA to explore associations between the demographic variables and the DAS21 and IES-R scales. So for question 8 on the checklist, I would say no appropriate statistical analysis was used. Whilst the authors were clear in what they planned to use, because they were interested in looking at an association between variables, this means the tests selected were inappropriate, as t-tests and ANOVAs are used to test differences between groups. Having said that, it does not look like the statistical analysis set out in the methods section was even performed, as results from the DAS21 were reported descriptively using mean scores and standard deviations. Having read the article and listened to me critically appraise it, how do you feel about it now? Did you agree with my ratings, or would you have rated anything differently? I'm now going to share my personal thoughts about the piece and offer suggestions about how I think it could be improved. I think this study is extremely disappointing. It deals with a very important issue, the psychological impact of COVID-19 on speech and language therapists, which is a topic of global importance. It is particularly important in the author's context, as Pakistan had one of the highest infection rates in the world, low testing rates and low vaccination rates, so it would be genuinely interesting to know whether the mental health of speech therapists there was worse than reported in other countries. It is also a topic of importance to me personally, as I worked in a hospital during the pandemic with patients with dysphagia, some of whom unfortunately died due to COVID. Unfortunately, the study suffers from significant methodological flaws. I contacted the authors to ask about missing data in the article, but they did not respond. If they do respond after this video is published, then I will add details in the description below. In terms of how the piece could be improved, I will give only a few examples. First, the authors appear to attempt to replicate a study by Rachel Rouse and Julie Reagan, who surveyed Irish speech and language therapists during the pandemic. I've included a reference on the screen and in the description to their article. The authors use a shortened version of the same title. They appear to also exclude therapists working with paediatric dysphagia, and they use the same psychological measures that were used in the Irish study. Rouse and Reagan's paper is cited in the reference list, but not directly in the article itself, which is surprising given its importance. It would have been appropriate to include it in the literature review on page 1408, where the authors mention specific investigations into the psychological impact of COVID-19 on SLPs working with dysphagia patients is limited. The study could have been improved by simply replicating more of the methods used in the Irish study. When the authors used a different approach or method to the Irish study, it was not only consistently worse, but usually methodologically flawed too. Second, the description and reporting of data in the study needs to be significantly improved. At present, most data about the participant demographics, the methods, the statistics and findings was simply not reported in the study. The lack of clear reporting begs the question whether the study even answers the research question. The authors reported most of the participants they recruited had 1 to 2 years of experience, but because it is not clear that the data was collected during the pandemic, it is possible that the largest group of participants were not even qualified and practicing during the pandemic and may have been students instead. If they had qualified, then they would have been newly qualified professionals, and this would have been a confounding factor to take into consideration. Third, the interpretation of data that was reported needed to be more accurate and conservative. Despite suggesting some reasonable limitations of the study on page 1409, especially around the cross-sectional design precluding causal inferences regarding the psychological impacts observed, this did not stop the authors concluding the article by highlighting the vulnerability of younger, predominantly female speech therapists to psychological distress in the very next paragraph. The authors had no evidence to back up this conclusion. The study did not report any statistical tests such as a chi-square test or regression analysis, the test for associations between demographic variables such as sex and age, and psychological distress. The study appears to come to this conclusion based purely on the fact that most of the participants sampled were young women. The suggestion that they were psychologically distressed can also be challenged. The authors reported that the mean scores for anxiety and stress on the DAS-21 were notably higher compared to depression. This may be true, but it is hard to tell because of how the data is reported. What is more important for the reader to know is that the mean scores for the whole group across the 3 subscales are all in the normal range. Whilst there may be individual therapists who suffer from psychological distress, again we don't know because of how little data is reported, as a whole the group mean is in the normal range. The reader is not made aware of this and cannot infer this because the study does not describe the clinical thresholds of the assessments used, and the authors did not report their findings in a graph. The only way they would know this is if they were already familiar with the assessments being used, or they had read the IRIS study, which comprehensively describes the assessment tools it uses. If you found this video useful, give it a like and subscribe to receive notifications about similar videos in the future. You can also watch other examples of critical appraisal by clicking on the video on your screen now. If you have any comments, questions, or have a request for other research you would like me to critically appraise, then let me know in the comments below or get in touch with me on Twitter. Otherwise, thanks for watching and take care.